put them, the one to take a biopsy and the other to... It's okay?
Yes, yes. Okay, Dr.
You can hear me?
Yes, Dr. Amal, continue.
Okay. Which category she put to take biopsy, to decide to take biopsy from this one, or to give her a category 3? Thank you.
Now, I usually, if the lesion fits the imaging criteria for probably benign, I assign it a probably benign category. I discuss it with the patient directly. I give her all the options. I say we can follow imaging, we can do a biopsy, or you could have it surgically excised.
Okay.
If the patient is amenable, I am assigning what I think are fibroadenomas to the probably benign category.
Okay, thank you.
Any other questions from the panelists? Dr. Lamia, Dr. Muhammad?
Thank you.
No, thank you.
Okay, so let's shift for the attendees' questions. We have few questions for Dr. Gilda. The first question, in case of focal asymmetry with underlying focal fibrocystic changes, better to go for contrast-enhanced mammography or only follow-up after 6 months?
I have no experience with contrast mammography, so I am routinely following those patients with mammography. If I see it best on mammography, I'll follow her up in 6 months with a mammogram.
Okay, thanks, Dr. Gilda. Second question from Dr. Iman. Does single view asymmetry always indicate superimposition?
I would say most of the time it does. And if I cannot find a correlate of comparable size and location on the orthogonal view, I dismiss it at the screening setting. I don't do any additional views. I don't do anything else. But again, I have to see nothing on the orthogonal view.
Yes, okay. Third question from Dr. Nasreen. How frequent do you use ultrasound elastography to upgrade your lesions from BI-RADS 3 to BI-RADS 4?
That's a fascinating question. It's a question that you could also ask me about Doppler. You know, how often do I use Doppler? Well, I can honestly tell you I don't use either one very often. I have very specific requirements for others, but it is really the imaging features of a lesion on ultrasound that guide me, not the elastographic findings. If I see features that are of concern to me, elastography really doesn't help me very much. It's the same thing that I could say with respect to Doppler. I really rely, and I'm a traditional imager, so I rely on the mammographic findings, I rely on the ultrasound findings, and while I find some of these technologies interesting, and I think they potentially have a future down the road, practically speaking, when I have a patient in front of me, I don't use them very often. They don't change my decision to do a biopsy or not at all.
Okay, thanks, Dr. Gilda. The last question. If the patient have done MRI to characterize fibroadenoma, downgrading it into BI-RADS 2, if it is still looking benign, with no follow-up is required, I think she means that.
Honestly, I can't think of a single patient that I have followed that I thought had a fibroadenoma with an MRI. I am not routinely recommending MRIs or doing MRIs when I think it's a fibroadenoma. And so I'm not exactly sure how I would integrate it into my assessment of patients. If I think it's a fibroadenoma, I'm not getting MRs. The only MRs that I'm recommending are on patients where we know we have biopsy-proven cancer, and I'm looking to evaluate additional foci of involvement or looking at the contralateral breast. I don't use MR for fibroadenomas. I'm not sure if I understood the question, but I think that answers it.
Yeah, okay. One question was added. If there is a large focal asymmetry and in ultrasound there is nothing, and after follow-up, after 1 year, no abnormality detected or no abnormal lymph nodes detected. What's the next step? If there is focal asymmetry with no ultrasound correlation.
Okay, if I have a patient who has no prior films, because once I have prior films, I can look to see what has happened with that focal asymmetry. So let's take the scenario of a patient with focal parenchymal asymmetry, no prior studies. I bring that patient back. If I haven't done tomosynthesis, I'll do tomosynthesis. If I have some tomosynthesis but remain concerned, I will do spot compression views with tomosynthesis. I will then do a physical exam of that area, and I will do an ultrasound. If I don't see anything on the ultrasound and the physical exam is normal, I place the patient in the probably benign category, and I follow her up in 6 months. And if it remains looking benign in 6 months, then I would recommend another 6 months, which would be time for her annual study, and then another annual study after that. If I have prior films, I really sort of force myself to make a decision today. Once I have prior studies, if that parenchymal asymmetry is getting bigger, if it's increasing in density, if it's changing, then again, I look with ultrasound, and if I don't find a correlate, I would do a stereotactic biopsy. Once I have a change on a mammogram, it takes a lot for me to put a patient into the probably benign category. Keep in mind that if I have a mammogram from a year ago, that's 2 6-month intervals. What is another 6 months going to do for me? I already know that in a year, it has changed. And so that's why I said, once I have prior studies, I really force myself to think very critically about asking for a 6-month follow-up. I try to do whatever I have to do, whether it's physical exam, whether it's whatever I need to do today to try to figure out. And if I can't sort it out, I will do an imaging guided biopsy stereotactically.
Okay. Actually, there is a question left from the previous session for Dr. Jean, if it's still available. Okay, you can direct the question.
No, I don't think. I think, Mona, we are too late.
Okay.
Yes.
Okay, now we have finished the discussion time. Thanks a lot, dear speakers, Dr. Gilda and Dr. Kaslin. Dr. Muhammad, please, would you close the session? Dr. Muhammad?
Yeah, thank you, Dr. Gilda, and thank you, Professor Dr. Kathleen, and thank you for all audience and all attendees. And see you tomorrow in BGICC. Thank you.
Thank you. Thank you, everybody.
Thank you so much, everybody.
And sorry for keeping you all late. Sorry.
No problem.
Thank you very much. Thank you, Gilda.
See you tomorrow, inshallah.
Thank you, everybody, for the chance to participate.
Yes, thank you so much. It was nice having you, Jessica, with us. Yes.
I'm quiet to listen to everybody.
No, yes. But we see you from since you entered
the start, yeah.
But you should try the platform, Jessica. You should try entering the conference through the platform.
Okay,
I would like to end the day today, so we can stop our streaming for the day. Thank you so much, our dear speakers and chairpersons, my colleagues in the moderation, and our backstage IT team. I hope you all enjoyed our session today. Thank you for the over 300 participants from all around the world who joined us today. We are wishing you all can join us tomorrow from the start of the session at 1 p.m. Cairo local time. Thank you, and this is the end of the streaming of the day.
Thank you.
So we're still on the Zoom, Iman? We're still on the Zoom.